The fourth rule that we should follow is to establish and follow treatment sequence. And as an example, I'm taking this young patient who went to my prosthodontist's office because he was not satisfied with his upper incisors crowns. They were too small and too square, and he wanted them replaced. But you can see that the patient had multiple problems. He had active caries, he had inflammation of endodontic origin, both on the upper and the lower arch, and he had some eruption problems with the third molars. When we are making the treatment sequence for a certain patient, we have to remember that each treatment phase should make the next one easier, more efficient, and more predictable. We are all discussing when establishing the treatment sequence together, and we make sure everything is followed by us and by our patient. We think of treatment sequence as building a house. We need to build a solid and healthy foundation on which then we can add layer by layer to the final result. So we sent the patient to the restorative dentist to treat the caries, to verify the old fillings, and then he went to the endodontist to retreat the previously treated teeth. I needed the endodontist's assessment of these teeth because you can see one upper central incisor had a big bony defect, and I needed to know if this kind of teeth can be kept or if these kind of teeth need to be extruded orthodontically, so I know what objectives I can set in my orthodontic treatment planning. After extracting the third molars, the patient received 3 new provisional upper incisors crowns, and I had to meet with the prosthodontist and with the periodontist to discuss the possibilities of treatment in the next phase. So, because the patient wanted bigger, longer teeth, the prosthodontist needed space. That space could have been gained either by a surgical procedure for soft and hard tissue in order to gain gingival symmetry and offer space for new crowns for the prosthodontist. But this kind of procedure had some disadvantages, like poor crown to root ratio, deficient adhesion on the root surface compared to the crown surface, and anesthetic emergence profile, because the root is narrower than the cervical third of the crown. The second option that we discussed was intruding the 3 incisors orthodontically, gain symmetry of the gingival margins, and offer vertically and or horizontally the prosthetic space that the prosthodontist needed for new incisor crowns. This is exactly what we did, and because my teeth already showed signs of healing after the endodontist retreated them, I placed 2 mini implants between the upper canines and upper first premolars, bonded them to the canines, and used them as indirect anchorage for intrusion of the upper incisors. I used a limited appliance, and I intruded using stainless steel arch wires the 3 incisors until I gained gingival symmetry of the upper incisors. You can see that 5 months later, the prosthodontist already had vertical and sagittal space for new prosthetic work. In the same day as debonding, the prosthodontist put some composite on the provisional crowns in order to keep that space that was gained during orthodontic treatment. What followed is the standard prosthetic procedures, the laboratory wax up, which was then transferred into the patient's mouth with an indirect mock-up, and then the 3 incisors were prepared, and there were fabricated 3 ceramic crowns for the 3 upper incisors and 3 no-prep veneers for the left lateral incisors and the canine. You can see that 2 years later the result is stable. The incisors are inside the bony envelope of our patient, and we can see, definitely we can see signs of bone healing around the previously affected side. The patient, in the end, the patient is happy because we addressed his chief complaint, new crowns, better looking crowns with better proportion for the upper incisors, but we are also content because we established and followed a treatment sequence which solved all of his issues.